Okay, so on behalf of my co-investigators, I'm very pleased to present the results of the NEO-MONARCH study to you. This is a phase 2 neoadjuvant clinical trial evaluating the combination of abemaciclib and anastrozole in women with hormone receptor positive, HER2 negative early stage breast cancer. In hormone receptor positive breast cancer, estrogen stimulates D-type cyclins, leading to activation of CDK4 and CDK6. CDK4 and 6 then phosphorylate RB, the tumor suppressor protein retinoblastoma, which releases the E2F transcription factor. Release of the E2F transcription factor ultimately leads to cell cycle progression from G1 to S. This increase in Ki67 expression can be observed in tumor tissue samples by this increased rate of proliferation can be observed in tumor tissue samples by measuring the expression of Ki67. Blocking CDK4 and CDK6 should lead to a decrease in E2F expression as well as a drop in the cell cycling and a drop in Ki67. Cell cycle arrest may induce senescence, which may also induce a phenotype that's characterized by an immune cell infiltrate. The phase 2 NEO-MONARCH clinical trial is a study evaluating a cyclin-dependent kinase 4/6 inhibitor, abemaciclib, in combination with anastrozole in women with hormone receptor positive, HER2 negative early stage breast cancer measuring at least 1 centimeter in size. In this study, eligible patients underwent a core biopsy at baseline and were then randomized 1:1:1 to either anastrozole daily, abemaciclib plus anastrozole, or abemaciclib daily. This treatment was given for 14 days, followed by a second core biopsy. Other studies have indicated that Ki67 change from baseline to 2 weeks after 2 weeks of hormonally targeted therapy may be predictive of disease-free survival, and for this reason we defined our primary endpoint as change in Ki67 from baseline to 2 weeks of therapy. This Ki67 level was measured in a central laboratory at USC, and evaluable patients must have had a Ki67 at baseline of greater than 5% to be evaluable. 220 randomized patients were needed in order to achieve 50 evaluable patients in each arm. We calculated, or we assumed, that the mean reduction in Ki67 from baseline to day 15 would be 82% in the anastrozole arm and 91% for the combination arm. After that day 14 biopsy, all patients went on to receive combination therapy with the CDK4/6 inhibitor along with anastrozole for 14 weeks. At the end of that 14 weeks, another biopsy was performed. Another study has evaluated the combination of abemaciclib and anastrozole and has shown the regimen to be well tolerated at a dose of abemaciclib of 150 milligrams BID continuously. However, the most common grade 3/4 adverse events that were observed was diarrhea, and for this reason we utilized primary prophylaxis with loperamide for the first 28 days in our clinical trial. Shown here is our primary endpoint, which was met. This is the geometric mean change in each of the 3 treatment arms. Anastrozole yielded a geometric mean change in Ki67 from baseline to day 15 of 63%. Abemaciclib plus anastrozole yielded a change of 92.6%, and abemaciclib monotherapy yielded 90.6%. Both of the abemaciclib arms were significantly greater in terms of their yield change compared to anastrozole, with a p-value of less than 0.001. These waterfall plots here demonstrate each of the treatment arms. On the far left is your anastrozole alone, the middle is the combination therapy, and the right is abemaciclib alone. And as you can see, overall, you are seeing a greater reduction in Ki-67 for each of the individual patients with the abemaciclib-based arms compared to anastrozole alone. I would like to highlight that those patients who had an elevation in their Ki-67 shown here, here, and here, all had received their protocol-specified therapy and were compliant for the first cycle, with the exception of this starred patient here in the combination arm who had a relative dose intensity of abemaciclib of only 19% due to toxicity. Complete cell cycle arrest is shown here, defined as a Ki-67 of less than 2.7% at day 15. What you can see is that the abemaciclib-based arms significantly improved the achievement of complete cell cycle arrest compared to anastrozole alone. Shown here are the RESIST objective response rates. On the left, the radiologic response was 54.7%, and on the right, caliper response was 56.6%. Keep in mind now that all patients receive 14 weeks of combination therapy with abemaciclib and anastrozole, which is why I'm showing you all of the three arms combined together. Complete pathologic response was achieved in 3 out of 95% of patients who've gone to surgery, and there was only one patient who had progression of disease, shown here, who came off study early for that at week 12. Now what I'm going to show you is a picture from one particular patient. We have this ongoing analysis to look at the histologic changes induced by our therapy at day 15 and then at the end of treatment. Currently, we've looked at 20 to 30 patients, and we'll be presenting the full data set at a nearby meeting. This is one patient who received abemaciclib monotherapy for 2 weeks, followed by the combination therapy for 14 weeks. Just looking at the H&E stain slides, you can see that at baseline, the tumor is moderately differentiation with poor lobular differentiation. And by only 15 days of having abemaciclib therapy, you're beginning to see these lobules differentiate. And by cycle 5, day 28, we're seeing even more lobular differentiation. These histological changes are also followed by a decrease in Ki-67 at day 15 and also at the end of 4 months of therapy. Now these right panels here, these last 3, are the immune cell infiltrates. And what is interesting is at both baseline and day 15, we're not seeing any T cells infiltrate the tumor bed. But at the end of 4 months of therapy, we are seeing CD3 positive and CD8 positive T cells, but not regulatory T cells infiltrating the tumor bed. So this is a relatively novel finding, and that's why I'm piquing your interest for our next presentation at a hopefully soon meeting. The common adverse events are shown here. The most common adverse event experienced, as expected, was diarrhea, which was primarily grade 1 and 2. Only 4% of patients had grade 3 diarrhea, indicating that our loperamide prophylaxis was successful. In addition, I'd like to point out that the continuous dosing of this CDK4/6 inhibitor was associated with a relatively low rate of grade 3/4 neutropenia at only 8.2% of patients. So in conclusion, abemaciclib alone or in combination with anastrozole significantly reduced the Ki-67 expression compared to anastrozole alone after 2 weeks of therapy based on the geometric mean change and complete cell cycle arrest, and our study did meet its primary endpoint. Abemaciclib did induce profound cell cycle arrest defined by a decrease in Ki-67, and what I'll be showing this afternoon is that we're also observing a decrease in E2F targeted proliferation mRNAs and a reduction in expression of genes that are associated with senescence. Treatment of the combination therapy may induce immune cell infiltration characterized by an increase in total T cells, but that is not seen until after 4 months of therapy. And tissue analysis, which is a novel finding, is showing the tumor cells, the tumor bed actually goes through differentiation with, that can be seen as early as 2 weeks after therapy. The majority of patients who received the combination therapy did achieve an objective response. There were no new safety signals identified with continuous dosing of abemaciclib in combination with anastrozole, and these data support the further evaluation of abemaciclib in early-stage breast cancer. So we'd like to thank the patients and caregivers as well as the investigators who generously participated in this work.
Thank you, Sarah. So can you tell us whether there were any delays in surgery as a result of this neoadjuvant treatment?
So So I should explain, and I didn't on the study design slide, that patients who were identified as having clinical benefit at the end of 16 weeks were allowed to go on and receive 2 additional cycles of combination therapy. So this was at the discretion of the patient and investigator prior to going to surgery. But if your question is relating to whether or not toxicity was mitigating the ability to go to surgery in a timely fashion, we are not seeing that, and we'll be reporting that data at a future conference.
Thank you.
Nick Mulcahy, Medscape. Can you explain to us why this study is important, especially given the fact that there's already another drug approved in this class of drugs? What makes this unique or interesting or important?
Yeah, so there is one drug approved, palbociclib, currently in the metastatic setting. Another drug which may shortly be approved is ribociclib, based on the Mona Lisa 2 data presented at ESMO, but both in the metastatic setting. This is a fairly unique drug in that it can be given continuously, so we do not need to take a 1 week or more break every month with this therapy in order to allow neutrophil recovery. The other 2 drugs in this class thus far have been developed using a 3-week on, 1 week off regimen. During that 1 week off, theoretically, there's this concern that there will be a rebound in cell cycling that may actually promote resistance to this therapy. Now, we don't have any comparative studies comparing abemaciclib to these other drugs, but this is a theoretical benefit of this particular drug because the side effect profile is quite different. The other interesting point about this study is it's in early stage breast cancer. So while there has been a study evaluating palbociclib in early stage breast cancer, Cynthia Ma presented that a year or so ago in a small study with a similar design to this. This is a larger study with a richer molecular and histologic evaluation. And I think the data that's going to be coming out of this is going to be very helpful and important to us as we move forward and develop these drugs.
I'm just looking at this. Do you take the drug every day? Is it a daily?
Twice daily.
Twice daily. And any idea what it costs?
That hasn't been established at this point because this is not
it's not approved. Okay, yeah, fair enough. Sorry about that. All right, thanks. And so early stage, Dr. Arteaga, do you want to comment on that?
Yes, I do. Yes, I do. So I guess what she's trying to say is that this drug is not necessarily the same as palbociclib. This is not like Pepsi-Cola and Coca-Cola, correct?
Yes.
They may not be Pepsi-Cola and Coca-Cola. The other one is that this study provides an enormous opportunity to discover mechanisms of resistance to these combinations. Because think about it, you have the residual cancer, that is drug-resistant disease, and you can identify why is it that those tumors didn't shrink as much as others. You can identify some surrogates or biomarkers or genes associated with that resistance, and that's going to identify patients that in the future may need a triplet. Not all of them, but few that may need a triplet. So these studies, the opportunity for discovery is enormous with this type of approach, which is something that is very difficult to do in metastatic disease.
Thanks.
Yeah.
Could you tell us a bit more about the immune status of the cells, like the difference in the CD8 positive and the Tregs, what that means, and there's interest in TILs? Put that into perspective for us.
Absolutely. So the T cells that are infiltrating the tumor bed are cytotoxic T cells. They're T cells that are part of the active anti-tumor immune system. Regulatory T cells are thought to dampen the immune response to cancer. And we're not seeing upregulation or increased infiltration of the tumor bed by the regulatory T cells alongside the cytotoxic T cells at this 4-month time point.
Okay, great, thanks.
we're ready for our next speaker.